Radiation for nodal coverage, levels 1 and 2 tangents will cover most of levels 1 and 2 of the breast. You use high tangents, which place the superior border at the superior portion of the humeral head. Will treat levels 1 and 2. You use high tangents if the axilla is not dissected, e.g. ACOSOG Z11 patients. In terms of the supraclav, level 3, you treat this 50 gray, 2 gray fraction. Same patient setup, but you tilt their chin away. You set the supraclav field first. The superior border is the cricoid cartilage. The inferior is the inferior portion of the clavicular head. The lateral border is the lateral coracoid process, which is sometimes brought to the lateral edge of the humerus if you're really worried about the axilla. The medial border is the vertebral pedicles, and then you angle the field 10 to 15 degrees away to avoid the cord. Note that a posterior axillary boost is essentially the same borders as the supraclav, the same angle as the supraclav field, but you block the lung and you block anything that's above the clavicle. Mono-isocentric technique limits the field length to 20 centimeters, and inability to rotate the collimators of the tangents. The isocenter is set at the match line between the clavicular head and the breast tangents. You set the supraclav field first, again, inferior cricoid to the inferior clavicular head, which is where the isocenter is placed. The medial humeral head, the vertebral pedicles with the field angled 10 to 15 degrees away to avoid the cord. Then you half beam block the caudal edge of the supraclav field. Then you set the tangent fields. You half beam block the superior edge of the tangent fields at the match line. Otherwise, they would simply diverge into the supraclav field. You rotate the gantry to align the deep borders of the tangent fields, except you cannot use the collimators. Means you have to use MLCs to block the heart, etc. Again, the superior divergence of the tangents of the supraclav field is avoided by the half beam block. You can also use a dual isocenter technique if the breasts are too large, meaning the tangents are greater than 20 centimeters. You half beam block the supraclav but not the tangents, and then you kick the foot of the couch away from the gantry during the tangents to match the superior divergence of the tangents to the supraclav. So there's no half beam blocking of the tangent fields. You're just doing a couch kick to match the superior divergence to the match line of the half beam blocked supraclav field. You can rotate the collimators. This illustration here displays this quite well, where essentially what we have can be seen here is divergence and then divergence here, which is matched. So this would be a dual isocenter technique as long as this was not half beam blocked. Again, feet come away from the gantry, feet come away from the gantry. So the divergence superiorly of the tangent field is flush with the half beam blocked supraclav. Again, it's angled 10 degrees to decrease the spine dose. The posterior axillary boost is the same borders, but it's blocked for anything that's near the lung, and it's blocked for anything above the clavicle. In terms of IMN coverage, you cover the first to third intercostal spaces. Partially wide tangents can sometimes cover this if there's favorable anatomy and if there's not too much heart and lung. You verify light fields daily. Shallow tangents matched to an angled electron field is another way to do this. You set the border of the tangent 5 centimeters away from the sternum. You contour the internal memories in the intercostal space for ribs 1 to 3 with a 1 centimeter symmetric expansion. Then you do a matched electron field at the skin, angled 5 degrees less than the tangent, meaning it's more vertically, aka more towards the sternum. You then set the lateral border 1 centimeter contralateral to the midsternum, and a gap 2 millimeters between the supraclav and the IMN field. You choose an electron energy that encompasses the 90% isodose line. You can use 4 to 1 mixed photon electron. The downside is a cold triangle. You allow a min of 35 gray and a max of 130 to 140%. So you have this electron beam field coming in at a 15-degree angle relative to the tangent. Here's your IMN contour. Here's your medial photon tangent, border. Again, you're setting the border of the tangent 5 millimeters away from the midsternum. The downside is you're having this smaller cold triangle and this tiny little hot triangle. Or sorry, no, that tiny little triangle is the cold triangle. Posterior axillary boost is used to supplement levels 1 through 2 if not fully covered with tangents, superclav, or in situations where you want good level 1 and 2 coverage with ECE and an inadequate dissection. This is prescribed to the midplane of the axilla. Borders, again, the inferior is matched to the tangent. Superior is parallel to the clavicle. Diagonal medial is just inside the chest wall. Lateral is the humeral head. In modern practice, contour the lymph nodes that need coverage. If there's adequate coverage not obtained with tangents, consider adding a posterior field. Post-mastectomy radiation treatment, SIM volumes, you target the entire chest wall, scars, drains, reconstructed breast, and superclav nodes. Per the RTOG Contouring Atlas, the chest wall CTV includes the mastectomy scar and incorporates the clinical chest wall, including the skin, pec muscles, chest wall muscles, and the ribs. When you wire, the superior borders the inferior clavicular head, mid-sternal and mid-axillary line are the same, but use the contralateral intact breast to get your 2 centimeter below that margin for the inferior border of the chest wall. You place the isocenter along the central axis between midline and mid-axillary line, and then shift XYZ directions to the inferior clavicular level. Collimator is placed at 0. Calc point should be 0.5 centimeters anterior to the chest wall lung interface at the level of the isocenter. Wedges are field and field. CTV chest wall is 5 millimeters crop from the skin. Crop anything more posterior than the posterior aspect of the ribs, so anything that goes into the lung. PTV is 7 millimeter expansion. PTV eval, crop 3 millimeters from the skin and crop anything more posterior than the posterior aspect of the ribs. Dose for post-mastectomy is 50 in 2 gray fractions with 1 centimeter bolus every other day. If there's reconstruction present, you can do 50.4 at 1.8 gray per fraction. Some boost the scar plus 2 centimeters to 60 gray. If there's no reconstruction, you can boost the scar plus 2 to 3 centimeters to 60 gray. Otherwise, if there is reconstruction, then it's hard to know where to boost, so generally don't. Unless you're working closely with a surgeon who can identify the area. We generally don't do this unless there are adverse risk features like a positive margin. There's no evidence that local recurrence are near the scar. In the modern era, the scar doesn't even correspond to the tumor bed or the margin. No hypofractionation yet for post-mastectomy radiation plus regional nodal radiation in the UK. In the US. It was included in UK Star B, and there's an ongoing alliance trial.